My name is Saad, and today starts with a dream, a goal, a desire for success. Last February, I told myself that within this year, 1 year from this date, I will do a root canal. Today is that day where I have finished my first ever root canal. Now, we did a root canal treatment on my patient, and after that we did an indirect composite overlay buildup, but that will be in the next video, so subscribe for that. As I'm recording this video, I have done a few more root canals after that, but I just want to share my first ever root canal experience, and hopefully you guys can learn something from this. So let's begin the story, shall we? It was a cloudy, windy day in autumn of 2021. I'm sitting at home on my couch when all of a sudden my phone goes off. I get a message on Instagram from one of my patients saying,
"My tooth broke, or half of it, I'm not sure. Can't really tell, and for the last week my gums keep hurting underneath that spot, even though I brush it like 2 to 3 times per day. I call a few dentists, but they don't speak English, so I don't even know what to do as far as drugs are concerned. So I thought maybe I could come to uni and you and your teachers could see it and give me some advice."
I booked in my patient for a checkup, and it kept getting cancelled because of one thing or the other, and things kept coming in the way, but eventually we got our appointment. Good morning everyone, my name is Saad, and today we're starting our day off with a root canal. I'm on my way to uni. Let's just do a day in my life, shall we? Here we go. She came in, I looked at her teeth, and this is what I saw. Yep, that is a big carious lesion on LL5, her lower left fifth tooth, on the distal surface, which was causing her an immense amount of pain. To see what she had, I did the percussion test, the hot and cold test, and then we got a radiograph to differentiate between pulpitis or a deep caries. And this is what we saw on the radiograph. As you can see here, there's a big carious lesion that extends from the distal and occlusal surface and moves towards the pulp. It contacts the pulp and completely engrosses it. This means pulpitis, chronica ulcerosa. The treatment for this is a root canal, and so our journey began. The first thing to do was to remove all of the caries, but because the pulp was affected, this was going to cause an immense amount of pain. She was already in pain, so we didn't want to cause any more for her. So what was the solution? Our teacher decided that we would do an intraosseous and an intraligamentary anesthesia. Now for the intraligamentary anesthesia, we hold the needle parallel to the long axis of the tooth and insert until we feel resistance. This is where we inject. The points of insertion are on the mesial, the distal, and the vestibular surface of the teeth. Now for the intraosseous anesthesia, we take the needle perpendicular to the long axis of the tooth, about a few millimeters lower than the gingival margin, so we're going into the root, and then we insert and inject. After the anesthesia was done, we waited for about 5 minutes for the anesthesia to kick in. Eventually she couldn't feel the tooth and we could proceed with the treatment. I used a round diamond burr and a fast handpiece to remove all of the caries that was on the enamel. Once we're done with the enamel and we got to the dentin, I changed over to a slow speed carbide burr, and then I took off the rest of the caries. In order to prevent the discoloration of the tooth later on, I had to take off the overlying enamel. So for this, we just used a straight diamond handpiece and went around the edges, making sure there's no overlying enamel. Whenever you're doing a root canal, make sure that you do take all of the overlying enamel off. You don't want to have any sort of discoloration later on. And this is what it looked like. Yep. That is a lot of tooth structure loss. Now at this point, normally we would have already applied the rubber dam, but unfortunately in this case specifically, there was no rubber dam available in the classroom, so I couldn't do it. So our teacher just recommended that I use cotton rolls instead, and I replaced them every 3 or 4 minutes. So I had a lot of cotton rolls and I kept replacing them. The tooth was isolated. But in all of the cases I've done after this, I've used a rubber dam. So I know people like to point that out. Here's some evidence that I do know how to use the rubber dam. Let's move on. Now it was time to begin the root canal procedure. So I grabbed the smallest K file I could find, the size 15 K file, and I placed it into the pulp cavity in order to remove the pulp. But the patient was still having some pain.
Ow!
What do you do in this situation? I decided to administer some intrapulpal anesthesia. So this is where the needle is injected directly into the root canal and into the pulp tissue. We need to make sure that we do it really quickly, otherwise the patient will have pain. So I finished doing the intrapulpal anesthesia and the patient felt a lot calmer. We could proceed. So I used K15 to remove the rest of the pulp tissue, and now it was time to find the apex. So to find the length of the root canal, we used the smallest file that could fit into the root canal, and we use an apex locator. So the apex locator has three main parts. There's the screen where you can see a visual representation of how far the file is into the root canal. We have the piece that attaches to the actual file, and then we have another piece that rests in the mount. So I took the smallest file and attached it to the apex locator, and I started going into the canal deeper and deeper. And you keep going until eventually you hear apex, 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 apex. It's a bit annoying, but this means that you have finally reached the apex. At this point, you can push the rubber stop on your file downwards, and then you know what your working length is. Take the file out, place it on an endodontic ruler, and you can see what your working length is. In some cases, the apex locator might just say nothing and then eventually just says over, over, over. This means that you have gone past the apical foramen, so you need to just pull back a little bit. When I say a little bit, I mean a little bit, because you could just go a tad bit and then you're too far up and you have to push it back in. So it's a bit long, but you'll get there eventually. Now I kept increasing the file size until eventually the largest file that could fit completely till the working length was file size K25 for me, and then the working length I found was 19 millimeters. Now as far as actual filing is concerned, there's two methods of filing that we can use. So there is the step back and the crown down technique. In this specific case, I used the step back technique. I started by inserting the 25 file till the apical foramen and filing all the way up, and then the 30 file all the way till the apical foramen and up. The working length is 19 millimeters, but because we're doing a step back technique, the next file, the file size K35, I only filed until 18 millimeters, and then file size K40, I only filed down until 17 millimeters. It's called step back because we step back the length that we're going to file the root canal. Now, as we are filing, we need to make sure that the debris doesn't build up within the root canal. We don't want any sort of debris just staying there at the end of it or going through the root canal, God forbid, and going into the periodontium outside. That would be a huge problem. So how do we avoid this? We avoid it by using irrigation and recapitulation. Now, irrigation is basically keeping the root canal lubricated. We take two syringes, one with sodium hypochlorite and one with hydrogen peroxide, and we're constantly injecting these into the root canal to make sure that all the debris stays in suspension and comes out of the canal. It doesn't stay in there. Now the second thing we do, recapitulation. Recapitulation basically means as we change the file from one K file to the other K file, we need to make sure that we use our original K25 file and put that into the root canal to the apical length and just move it about a little bit. Just make sure that the debris all comes out and make sure that we can still reach the apical foramen. This tells us that there is no debris inside and the canal is clean. Okay, so we're done filing. The next step is to get the root canal ready for the Gutta Percha. And to do this, we do our final irrigation with peroxide and hypochlorite. You might need to use EDTA in some cases. And then we use paper points to dry the canal off. It's time for the sealer. The sealer I used was zinc oxide eugenol sealer, and it comes in a powder and liquid form. These are mixed together on a glass plate with a metal spatula until we get a mayonnaise-like consistency. Once it's mayonnaise-like, it's ready to be put into the canal. So you grab a lentulo spiral, put it onto the slow handpiece, and put some sealer onto the lentulo spiral. Insert the lentulo spiral about halfway down the root canal. Start the lentulo and remove it. Put it in again, start and remove. And now you've put the sealer all over the root canal. Grab a Gutta Percha that you should have already tested to make sure that it fits the working length of the root canal. Then you take this Gutta Percha and mark exactly where the working length of the canal is. Put some sealer on the end of the Gutta Percha and put it directly into the root canal. It should fit into working length. If it doesn't, then there probably is some debris there and you need to fix that situation. So in my case, I put the Gutta Percha in there. It fit perfectly and I knew I was at working length. There were still a few gaps, so I had to put a few other Gutta Perchas right next to the original one just to fill in all of that space. This technique of putting more Gutta Perchas next to the original and pressing them against the wall is known as cold lateral compression. Once I put the Gutta Percha in, it was time to cut off the end. So for this, we just grab a lamp, heat the cutting instrument, and then cut off the tip of the Gutta Percha near the pulp floor. Once you've done this, it's time for the moment of truth. X-ray time. We needed to get an X-ray to see if the Gutta Percha was smooth, if it had filled the entire canal, and if we were ready to do the rest of the build-up. So I took my patient to the X-ray department, and here's what came out. So I'm currently outside of the radiology department. You might have seen it in my uni tour. Let's see how we've been doing so far, yeah? Let's go. Success! Yay! Finally, I finished my first root canal. I was so proud of myself. It looked good. My teacher said that it was fine and we could move on to the next step. Now, this is what the tooth looked like after we had completely finished doing the root canal procedure. As you can see, a lot of enamel was lost. And later on, we found that there was a bit more caries left under the enamel, so we had to take a bit more off. And because so much was lost, instead of doing a normal composite buildup, we decided to do an indirect composite overlay. Once I was done with the root canal, I applied a temporary filling material into the canal because our lesson had finished. For now, I just want to say a huge thank you to my teacher, Professor Manchurova, for all of her advice and all of her help through this first root canal. If she hadn't helped me, I probably would have been a bit lost. I ain't gonna lie. It's very scary. You know, the thing is, you learn all of this theory, but when you actually go into practical, it's a different situation, and she was just a huge help. So big shout out to my professor. Thank you so much for your help. Now, with every treatment, I feel like you need to improve yourself and see what you've done wrong and what you've done right. So let's go through that. What I did correct. So the first good thing that I did is that I planned beforehand. This was very important because if I hadn't, I would have been completely lost. I had made my notes, I had the pictures of the x-rays of the patient, pictures of the tooth, I knew what I would need to take off, what was the first step, what instruments I needed, all of that sort of stuff. Second thing that I feel like I did really well is I made sure my table was organized. Before I began the procedure, I took all of my K files, set them in an organized manner on my table, took my syringes, got them ready with the irrigant, took the Gutta Percha and had everything ready on my table before I even began. It just made life so much easier when I was going because there's so many different instruments we needed and I feel like it saved me a lot of time. Another good thing I think I did is I asked my teacher when I have doubts. The thing is, I am still a student at the end of the day. I'm not an expert. So it's really important for us to be able to speak to our teachers and ask them for advice. And I'm not going to hesitate. If I have any doubts, I'm going to go to my teacher. And I went to her. She was really helpful and she helped me out throughout the whole procedure. So thank you for that. Things I learned. Now, the biggest thing obviously is that I did a root canal procedure. I know how to do a root canal procedure properly now. Because when you're doing it in the actual clinics, there's lots of little bips and bobs that you don't learn about in a book that you need to apply in a clinical scenario. And I feel like I learned all of these little bits and bobs. So now I feel a lot more confident doing root canals. I also learned how to use my loops properly. I'm not sure if I've shown them before, but these are my loops. And I finally learned how to use them properly. They're supposed to help with your posture, but I had never used them in a clinical scenario because they were still brand new. And I actually got to use them and I realized that they actually help so much with your posture. You see, you can sit down properly, just look through the lens. Everything is so close by, it's very clear. For root canals, I highly recommend get yourself a pair of loops. Yeah, this is an essential if you're going to do root canals. It just makes life so much easier. I also learned how to determine the length of a root canal. So learning how to use an apex locator, seeing the different measurements, the responses that the apex locator gives you, how much pressure you need to apply onto the tooth, how to go into the tooth properly to get to the apical foramen, all of that technique. I think I learned that really well now. I also learned what to look for specifically for pulpitis chronica ulcerosa in an x-ray. Oh, by the way, this was the before and after x-ray. Taken about a week between each other, and as you can see, there's already some healing going on around the apical region of the tooth, so the root canal was a success. Now in the next video I'll show you how I did the indirect composite overlay for this patient, which was really interesting thing to see, and I think you guys will find it interesting as well. So if you are new around here, hit that subscribe button, you don't want to miss out. My name is Saad. Thank you for watching and I'll see you guys for the next clinics. Goodbye.